So good morning, everyone, from sunny Tel Aviv. This is 11 a.m. I hope this webinar in this crazy period finds you in good health and good spirits. I know that we have more than 350 registrations, and here we have around 200 participants, and I can see the distribution of the countries. So hello everyone. We have people from Thailand, from Malaysia, Indonesia, Philippines, New Zealand, Japan, Taiwan, China, Germany, Holland, Israel, UK, Belgium, Peru, Brazil. So we have many people from many countries. So first I thank everyone for joining, and I feel privileged to talk about this novel technology, novel device, the TIXEL, and the TMA, the thermomechanical ablation technology. In this webinar, I'll do my best. I have 3.5 years of experience, and I'll do my best to expand your knowledge and horizons working with the TIXEL. So as you can see, and please have a look, when it is not used, the tip, now you can see the tip is getting out and in from the handpiece. So when not in use, the tip is base positioned at the distance with the skin, and by activating the handpiece, a linear motor rapidly advances the preheated to 400 degrees. We have a 400 degrees titanium tip. It advances the preheated tip to skin surface at a predetermined protrusion. We're going to talk about it in a second for a brief duration. Please have a look. I'll start with more the physics and the general overview over the device. So if you can look at the tip, we have a tip. It's 1 on 1 centimeter, and it is made of gold-plated copper paste, and it is shell. There is a titanium shell. This design makes it biocompatible even at high temperature, and we really see no corrosions, and this is very important. If you look at the tip, we have, it consists of an array of 9 on 9. So we have 81 square based pyramids, and the pyramids is 1.25 millimeter tall, and it has a flat, it is very important, you will see in a second, it has a flat rectangular apex, so it is blunt, it's not sharp, and the surface area is approximately 0.01 millimeter. It is important because we do not really puncture the skin. We push the skin, and this is very important why we have blunt tips. One fact which is important is the sterility of the device. So as you can see, the tip, I'm sure we have people who use the device, so the tip is reusable. And how to check, how to validate, how to clean, and how to sterilize itself automatically. So you will see when it gets to 350 degrees Celsius, it stops, so it is blocked. The operation is blocked for 3 minutes till it gets to 400 degrees. These 3 minutes are used for sterilization. So this is the device. This is the TIXEL C. We have the TIXEL 2. The TIXEL 2 will allow 2 handpieces to be connected. And we have, as compared to lasers or radio frequency, we have 2 parameters which are very important. One, it is exposure time. So while talking about exposure time, you will see in a second is the time that the tip is going out, touching the skin, becoming in contact with the skin, and coming back to its original place. And we have protrusion. Please have a look. Again, I told you we do not have pins, so we do not protrude the skin, we push the skin. While talking about the protrusion, it is measured, and I hope you can see, no, I think it's very difficult to see it here, but you can see we have the protrusion in micrometers. So this is a distance from the edge of the handpiece, from the plastic shield to the skin. So the distance that the pyramid is going out. So if this is the plastic and those are the pyramids, I hope you can see it. If it gets in, so it can, if it gets out, it can get out to a more distant parameters, and it can get less. So if we have more, or if we increase the protrusion, we have more what we call coupling. So for example, for you to understand, we know that between the tip and the skin, we have some air bubbles. So if it is pushed in a better way, we will have less gas bubbles. So higher protrusion will reduce the air gaps, and it will allow us better thermal matching, or what we call coupling. It is important to say, and this is people who really specializes and have experience with the device. For example, if I use it in flexible areas, for example, the cheeks, okay, in which we do not really have a bone, I have to increase the protrusion in order to have the same effect compared, let's say, to a more rigid area, the forehead, in which I decrease the protrusion to have the same effect. The second parameter is the pulse duration. Again, I told you pulse duration is the time that the tip is going out and in. It is measured in milliseconds, and please have a look at this diagram. So you can see the 400 degrees, and you can see this is on the y-axis, and you can see it is going down with temperature till 50 degrees. The curves represent different depth. So the light blue, it's a dark blue, so the upper one, this is the temperature while we are on surface. So it is 400 degrees. If we get deep, and I'm talking about a depth of 100 micron, this is very superficial, we decrease dramatically the temperature. So from 400 degrees, we get to 50 degrees, and it is very important. So most of the effect is very superficial. And if you look at this, what we call mathematical or illustration, you can see that we have hemispherical heat wave propagation. But generally speaking, we're talking about stratum corneum, epidermis, and superficial dermis. So we're talking about very, very superficial effect. Let's look how it looks from up. So this is a dermoscopy. Okay, this is a picture that was taken with a dermoscopy. So you can see from above, first we have kind of a crater which is clean. We don't have carbonization. For the people who are familiar with lasers, usually you see some blackening, some carbonization. It is fractionated, so it is spaced. So you have an area of treatment which is separated by a non-treated area. And we have no bleeding as compared to different laser. I have to remind you, we transfer heat. So the heat transfer is not related to any chromophore-like laser. This is maybe the most important slide in this webinar. Please have a look. So whenever you have any distributor, any company which sell devices that come to you with a new technology, you have to ask for histology. As you can see, we have high setting, we have medium setting, and we have low setting. Let's look at the low setting. You have the depth, the width, and the coverage. If you look at the histopathology images at low setting, you can see that the thermal effect does not really vaporize. Have an hemispherical pattern of injury. We don't see really an ablated area. You have mild or slight coagulation. And if you go to the very high setting, it will be very important in a second, talking about the clinical indications. So while talking about the high setting, then we do have some ablation. So you see we have uh, um, um, some blister, what we call between the epidermis and dermis. We have a change in the basket weave structure. Of course, we have a change in the epidermis. There is some ablation, and we have coagulation. And what we see, you see quite wide triangular coagulation or pyramidal coagulation, which I will show you in a second. It is much larger compared to radio frequency. So let's try to compare, because for the people who are less familiar with TIXEL, I'm sure you all understand and are familiar with lasers or radio frequency. So I'll start being simple. So we all know that while talking about fractional ablative CO2 laser, we have ablation and we have much coagulation. While talking about fractional ablating erbium YAG laser, we are talking about mainly ablation, but we have some coagulation. The non-ablative fractional laser, we have no ablation, but we have coagulation, less than CO2 laser. Radio frequency devices are proud to have to cause to promote remodeling and coagulation. They have very slight, if at all, ablation. But let's talk about TIXEL. So you saw the histological images. So with the high setting, there is some ablation, some coagulation. With the low setting, this is totally non-ablative. There is no vaporization of tissue. So what do we have? This is a new concept. It will be more clear in a few slides, but we are talking about dehydration. Because of the transfer of heat, pure heat, into the superficial structures of the skin, we dehydrate the stratum corneum, we make it more brittle, we dehydrate the epidermis, and it will make it, and you will see in a second, it will make it very important while talking about drug delivery. If we really compare the energy, and this is again very important, so you have a comparison between TIXEL, between short pin RF, blunt pin RF, and CO2 laser, and we are talking about the energy per pixel or per pyramid. So you can see the range of energies, even with a different pulse duration of TIXEL, as compared to the range of 4 to 62. With short pin RF, with blunt pin RF, it's 10 to 62, and CO2, it's much higher. So while talking about TIXEL in general per pixel, the TIXEL applies much less energy compared to any other modalities. Please have a look. This is a comparison with the pin radio frequency. So if you look at the same energy and you compare between TIXEL and radio frequency, we have a larger volume. So the coagulation zone is much wider compared to radio frequency. And the reason for it, it's always about how you use your energy. And we know, because we do not really get to, we do not have chromophores, we don't have an electrical current, which then it is transferred or it is changed, transformed into heat. This is pure heat. So the TIXEL is substantially more effective or more efficient in energy transfer compared to radio frequency technologies. But in my talks and in this webinar, I will stop being somewhere in the sky and I'll start being practical. And I'll try to be clinical in order to come with very, very, I would say, um, concrete recommendations, indications, and of course, this is my experience. While when I think about the device, I have in mind two directions. The high setting, which is pulse duration above 10 milliseconds and high protrusion above 500 micrometers, and the low setting, usually it's 6 milliseconds, and low protrusion, usually it's below 500 micrometers. So those are the two directions. While talking about the high pulse duration and the high protrusion, and I want to share with you, this is a new slide, so I've never shown it. I hope Ariono is in the crowd, is between the participants. But this is a study that now we're finishing. We're actually reviewing the results of the high setting of TIXELs. So altogether, we have 44 photographs of 22 patients, so 22 right-sided picture and 22 left-sided picture. And I want you to try and to appreciate what are the changes. So this picture, along with many other pictures, were sent to 4 non-involved dermatologists who had to rate the improvement. What do you say? This from one of the evaluation of one of the doctors, but I can tell you, because I summarized already the result, that with the high setting, so high pulse duration and high protrusion, if we take this, I would say, London, Tel Aviv patients, or English Israeli patient, because half of the patient is from Hariono's clinic and half is from my center. So the main changes with the high setting is the change of periorbital wrinkles, and there is a change which sometimes it's very difficult to quantify, but there is a change in complexion. The skin looks more vivid, something with the healthier, the health of the skin looks much more healthy. So talking about the periorbital wrinkle, and again, this was part of the evaluation, but I do have to mention, we finished, I think it was a 2-year, maybe even more. It is an American-Israeli study, and we showed that by performing few treatment, it's not one treatment, it's usually between 3 to 6 treatment. You can see the before and the after. We have an improvement of the periorbital area, mainly the wrinkles, the wrinkly appearance, and this is very important. So we use it with the high setting for rejuvenation. I usually do not use it with the very high setting. This is a picture from London by Dr. Ariono. You can see the setting, and I'm sure you can appreciate the result. In a minute, you will see the downtime. I usually use the TIXEL in a lower setting. Still, I consider it to be high setting with different, I would say, cocktails. So different biopeptide, different drugs, mainly tretinoin 5%. I really like to combine my TIXEL with other modalities. I think one of the main modalities, one of the main protocol in my clinic is IPL. It doesn't really matter which IPL you use. I have to say that I tried it. I have 4 IPL devices in my clinic, so I tried it with all. So IPL followed by TIXEL. Usually my setting is 10 millisecond and 5 to 800 micrometer protrusion. I usually apply biopeptide. It's a combination of, again, different countries have different formulations, and I just top it with tretinoin 5%. Please have a look at the change. Again, I get back to the original comparison of this British-Israeli comparison. There is a very dramatic change in the periorbital area. The complexion is nicer and the skin looks more vital. This is in higher magnification. Again, if you go higher with the setting, this is again pictured by Harionos. So you can see with the high setting, you will have longer downtime as compared to the low setting, in which we have relatively short time. And again, as compared to other devices, the treatment in general is easy, well tolerated, and again, complexion, skin is more vital. We have an improvement in the periorbital wrinkles, along with other changes, but I elaborated the main changes. Let's talk about the healing process. First, I have to tell you that within 1 day, we have completely regenerated epidermis. There is a work which I really like by Maya Hoffman, Professor Hoffman from Berlin, and she compared the wound healing process after TIXEL compared to after CO2 and after radiofrequency devices. I was surprised, I have to say, but again, this is it makes sense. So while looking at her result post CO2 laser, so you can see that still skin damage, and I'm talking about subclinical. You can't see it. Sometimes the skin looks red, but if we look inside the skin, there is still skin damage even after 20 days, and I'm talking about after CO2 laser. While talking about radiofrequency, after 14 days, still we see wound healing process. So we have to wait some more weeks. As compared to those different modalities, while talking about TIXEL, at 14 days, we have complete regeneration of dermis, all structured, regenerated. So you can actually do treatment more often. So nowadays, while talking about CO2 laser, I usually wait at least 8 weeks between treatments. While talking about radiofrequency, I usually wait 4 to 5 weeks between treatment. And while talking about TIXEL, I have to say that after seeing this study, you have the reference, so you can read it. I wait a shorter period. So my intervals are actually shorter. Usually it's 2 to 3 weeks between treatment. So we talked about the high setting. Let's go to another direction and let's talk about the low setting. And while talking about the low setting, I'm talking about the low pulse duration, 6 milliseconds, and low protrusion. I told you less than 500. So if it's the forehead, go lower. If it's, let's say, the cheek, you have to go higher. What do we have here? So we agreed, no ablation. We agreed, we have minimal coagulation. Dehydration, I mentioned. So let's see what it contributes. So we know that most of the topically applied medications or cosmeceuticals, they're poorly absorbed into the skin. And in order to be absorbed, they have to actually pass the rate limiting step. We're talking about the stratum corneum. This is a very, very thin layer. And even if we want to cross this very thin layer, the compounded formulation or the drug, the cosmeceutical that is topically applied, it has to be with very, very certain characteristic. This is the reason that in the last 30 years, there have been so many efforts in order to what we call enhanced drug delivery. I will not get into details, but of course you can change the drug, you can change the vehicle in order to make it more, in order to push it, I would say, into the skin, to make the skin more permeable to this drug. You can add some what we call vesicles. For example, in Israel, it's very common to use liposomal gel together with many of our formulation. Again, it assists, it enhances drug delivery. You can modify the stratum corneum. The main example is hydration. We can hydrate the stratum corneum. We all know in dermatology, when we apply topical medication, under occlusion, we have better penetration. But you can do some other, I would say, more active, or you can use more active methods. First, you can use different modalities in order to push, I would say, to change, okay, the parameters of the skin. So you can use iontophoresis, you can use electroporation, sonophoresis, magnetophoresis. So again, changing the environment in order to change the structure of the epidermis, and mainly the stratum corneum and the epidermis, in order to allow drug delivery. But what we all aware, and this is a very hot topic, is ways to bypass stratum corneum. You can do it with microneedling, derma roller, very limited, I have to say. You can do it with different fractional ablation or different fractional ablative devices. So you can use lasers. You can use radiofrequency, and I will show you how to do it, or why it is very wise to do it with the TIXEL. So few words about laser-assisted drug delivery. This is, I would say, an evolving field. So as compared to 15 or 20 years ago, there are more and more publications showing that if we actually create those holes within the skin and then we apply a medication, these, and you can see the particle, you can see the illustration, these particles will get into the channels and there will be more homogeneously uptake into the skin. It was proven that as compared to all other modalities while using laser-assisted drug delivery, we have more homogeneous uptake. You can see this compared to the non-ablative fractional laser, microdermabrasion, and microneedling. And again, this is a very, very important concept. However, talking about laser-assisted drug delivery, there are many drawbacks. First, because of the very, very, I would say, heat transfer into water, we have kind of a geyser. And this very, very high temperature create an explosive effect, which it's not with any CO2 laser, but with most CO2 laser will end up in carbonization. This is the reason we have blackening as compared to what I previously showed you. And this decreases drug delivery. We know that coagulation zones serve as a sponge from which drugs will be diffused into the skin. Coagulation zones are important, but if we have too thick coagulation zone, again, it will decrease drug delivery. We know that within few minutes, and this is even more prominent with other modalities, not laser-assisted drug delivery, we have blockage, debris, fibrin is getting into the channel, and it will actually decrease drug delivery. But this is not the main important factors. First, it's complicated. If we want an energy-based device as a device which will help us to push material drugs into the skin, it has to be compact, it has to be small. We can move it from a place to place. It has to be a device that we do not need an ocular protection. If you treat around the eyes, you will have to insert a metallic eye shield. You make it too complicated. And we have to have a device that it's not painful. And I have to tell you that lasers in general are painful. And this is very, very clear, because while talking about pain nociceptors and pain stimuli, which is transferred into the CNS, we have two main transmissions. We know the delta fibers and we know the C fibers. The delta fibers usually transmit short pulses like lasers. as compared to the C fibers, which usually transmit long pulses. We're talking about milliseconds. And this is the reason that, especially with the low setting, and I will show you a video of a child in a second, it's not painful, okay? It's unpleasant. It is sometimes felt, but there is no comparison to other modalities, neither lasers nor radio frequency devices. So let's talk about drug delivery with the low setting. So if we have to begin with a wet sponge, okay, which imitate a wet stratum corneum, even wetter epidermis, while transferring pure heat into the skin, we dehydrate the stratum corneum and epidermis, and it makes it more susceptible. So whatever you put on it will just be absorbed into the skin. This is a very, very clear physical law. What you can use, this is your imagination, but we know that again, while dehydrating the skin, especially if we dehydrate the skin, we make it brittle, and then we have this punching, the motion of the device, so we break the stratum corneum, we enhance drug delivery. This is the first publication that came out, I think it was already 2 years, it was 2016, it was 4 years ago. And this study evaluated the effect of TIXEL on skin permeability of 3, you can see it is mentioned here, of 3 hydrophilic models, so verapamil hydrochloride, sodium diclofenac, and vitamin C. And the experiments were carried out partly in vivo, in humans using fluorescent dye and confocal microscopy, and partly in vitro using porcine skin and France diffusion cell systems. And this very first, I would say, TIXEL-assisted drug delivery publication showed that as compared to just topically applied medication, dose medication, if you first TIXEL the skin and then you apply those 3 models, 3 medication, you have an increased concentration in the epidermis and in the papillary dermis. And this is very important, especially while mentioning and talking about different studies that I performed later. Another study that has to be mentioned, I don't know if Christine Dierix is part of the participants, but dear Christine Dierix and Ronen Shavit, they published, it was last June, it was actually the editor's choice work, and they showed that while performing low setting TIXEL parameters, we perforate the stratum corneum with minimal coagulation. We dehydrate the tissue, of course, the stratum corneum, but we're talking about mainly about the epidermis. So we have a very low water content. So if we put any topicals on the skin, it will enhance the delivery of this topical. You can see the comparison. You have the fluorescent. It was performed with ALA again, so it's a more complicated this material because you actually don't measure the ALA, so you measure the porphyrin 9. But again, if you see the fluorescent, so after 3, even after 1 hour, but furthermore, after 2 hours and after 3 hours, as compared to control, you have higher concentration of the material. And they even showed us that while using 6 millisecond and 4 micrometer, these are the best setting for drug delivery. But again, I have to say that it's very important to know what you do. So if you use these settings, for example, on the back you won't have good results. It is when using this result on the face, I'm sure you will have a very nice result. In this publication, they even showed that we need to have different formulation, and this is again very important, so we know that it is not just up to the TIXEL. So different formulations will behave differently. Based on this study, we performed a study. This is a retrospective chart review of 30 patients. It was published a few days ago. We perform for our acne patient, acne vulgaris patients, we have the same protocol. We do TIXEL, followed by ALA 5%, 1 hour incubation, and red light. We use the Omnilux in my clinic. It was a retrospective chart review, so we took all the patients that were treated with this method between 2018 and 2019. You can read all the demographics and all details in this already published articles, and we try to evaluate the change. So we use different scoring system. I will, again, in the sake of time, I will not get into details, but you can see we have some objective, non-involved dermatologist evaluation, and we have the PGIC, the Patient Global Impression of Change evaluation. And one thing to really mention, again, you can read all publication. It was published a week ago. So we had altogether 30 patients. 63.3 were female. You can see the average age. You can see we're not talking about new disease. So we took patients that were resistant, or they refused another cycle of mainly oral isotretinoin, and you can see the change. So if you look at all scales 8 weeks after last treatment, okay, and we did between 1 to 3 treatment, you can see we have a dramatic change which is maintained, and you can see the clinical picture. My experience, and again, this study has many limitations. It is a non-controlled retrospective chart review, and we didn't compare it to higher ALA concentration, though I know, and this is my experience, that with higher ALA, I have longer downtime and many adverse effects. We didn't compare it to conventional PDT, who says it's better. But again, from my gut feeling, and this is the reason that we published it, we have really good result. It's non-painful device for assisted, I would say, enhanced photodynamic therapy. One thing that I do have to mention that still we cannot, and I emphasized it in the publication, we cannot really say what is the how it works. So we know that by performing first the TIXEL, we bypass the stratum corneum, we allow the ALA into the epidermis, but from the epidermis to the dermis, we don't really know what's going on. Maybe there is some effect on the skin flora, which makes the changes. But again, it still has, I would say the final conclusion on the mechanism, it still has to be elucidated. Another area that we have actually few years of experience is the treatment of TIXEL in rosacea. Again, this is a publication from 2 years ago. And it all started with this patient. This patient was resistant to all modalities. We tried every modality in the literature. So as you can see, we try oral, topical, we even tried IPL and pulse dye laser. We had some improvements, minor improvements, but in general, it always recurred. She came actually with, I would say, Professor Google and the recommendation of treating rosacea with injection of botulinum toxin. These are the publications that she came with. So I told her we can try injections, and she didn't want to be injected. And then we offered TIXEL followed by the topical application of botulinum toxin. Why it works? Again, many speculation. One of them is by Dayan. Is a very nice. It is a very nice publication, and maybe it blocks the relationship between the nervous system and the vasodilatation system. But again, this is just a speculation. So from this patient, again, this is the publication. We had 16 female patients suffered from resistant rosacea. We did 2 treatments with 1 month interval. We first did TIXEL, then these were the parameters. Nowadays, I use different parameters because of Christine's publication. We topically apply botulinum toxin. This publication came out with Dysport, and in this publication we used sonophoresis in order to really enforce the toxin into the skin. Nowadays I know that this is not needed. So nowadays I actually use a vascular laser, so usually pulse dye laser or IPL, followed by TIXEL, followed by the topical application of botulinum toxin. But again, I'm describing the publication. Before and 1 month after last treatment, we took Demodex culture. We measured with Mexameter the erythema index. Of course, all our patients were photographed, and 2 non-involved investigators. They assessed the change. Again, I will try to be more quick in the sake of time. We ask our patient to rate the change by themselves. Of course, we evaluate the dermatological life quality index, tolerance. Every adverse events were recorded. So you can see, again, I will skip it because I'm sure you can read the publication, but I want you to look at the result, which I believe very interesting. And nowadays we have more than 200 patients experience. First, before and 1 month after treatment, there is a drop in Demodex folliculorum culture. Maybe it's the heat, and maybe this is part of the mechanism by which it works. But if we look, and this is the redness, so you can see the erythema index, and you can see the objective and the non-objective scoring system. If you look at the diagrams, both diagrams, we have very, I would say, red people. And then 1 month after 2 treatment, it gets much improved. And then it gradually recur, but it doesn't get back to the original state. It's very interesting, but 6 months after last treatment, the dermatological life quality index were lower. You can see the before at 1 month and at 6 months, and we have really many patients with this improvement. I cannot really explain why it works. Is this, maybe it's the TIXEL, maybe it's the TIXEL assisted drug delivery of botulinum toxin. We know that with just performing TIXEL on rosacea patient, we didn't see such improvement. But again, the mechanism is still, it has to be elucidated. While seeing that using TIXEL followed by the application of botulinum toxin is successful, I was trying to think of other uses. This is a study that was written by Dr. Bar-Ilan, and by other people. It's never one person's work, it's always a team work. So I'm not sure, I don't know how many dermatologists we have among the participants, but Haley is a very aggressive, it's very difficult disease. It usually involves the axillary areas, the groin area, the submammary areas, and usually we have blisters, and then it is much inflamed and infected by fungal infections, bacterial infections, and it's very, the smell is very offensive. We don't have treatment for these patients. One of the treatments that were described in the literature is the injection of botulinum toxin, but we're talking about large areas, and if you really want to inject, it's very painful, and you have a risk of infection, secondary infection. So we tried it on those Haley patients. First TIXEL, second application of botulinum toxin, two treatment, the same regimen as we performed with our rosacea patient, and very nice result. I didn't include it in this webinar, but in the study that is in the reference, you can see the study here, you can even see the histology. I use the TIXEL for many indications. For example, for melasma, which I'm sure this is not, it cannot stand as a monotherapy, but we use TIXEL in order to deliver tranexamic acid or hydroquinone or niacinamide. We use it for different, very unique indications. For example, one of the indications is hemangiomas. This is a publication that I was very happy that it was accepted for publication 2 weeks ago, and it is now awaiting to be on air, so it is awaiting publication. I don't know again if you see many infantile hemangiomas. This is very common. This is actually the most common vascular tumors in children. 4 to 10% of the children will suffer from infantile hemangiomas. We're talking about proliferation of endothelial cells. Usually we have the phase of rapid proliferation, and then we have the phase of involution. Most of the infantile hemangiomas do not require treatment, but if we treat, and this is the gold standard, mainly when we have hemangiomas which are thick or they're in a certain anatomical areas, the gold standard is the oral propranolol, and that's what most doctors do. But while taking oral medication, we have systemic side effects. So we experience, and our patients experience, sleep disturbances, acocyanosis, bradycardia, hypotension, although I have to say that the adverse effects are quite rare still. It opened, I would say, the market, or it opened this field of infantile hemangiomas treatment to the treatment of topical beta blockers. I included all publications with the treatment of beta blockers. And just to summarize, this is applied off-label. If you look at the publication, various concentration, various vehicle, different dosages, different application frequencies. Mainly we're talking about timolol and propranolol. We have to apply these medication for very long period. We're talking about up to 16 months. And we have result, but the results are not very sufficient if we talk about widespread or deep infantile hemangiomas. We do have systemic absorption with topical beta blockers. This is one of the references that was published a year ago in the JAD, and they showed that 93% of the patient with just topical, again, I'm not talking about TIXEL, I'm not talking about an energy-based device, just topical application. So 93% showed timolol in plasma samples. You can see the concentration, and eventually this study recommended to use 2 drops of timolol per day, timolol 0.5%, in order to avoid systemic side effect. So let's take it one step forward. Let's talk about energy-based device assisted delivery of timolol. So we weren't the first one to think about it. This is a study, 2014. This is CO2 laser-assisted drug delivery of topical timolol. It showed very nice result for the deep infantile hemangiomas component. This is another study, a relatively new study, February 2020. We're talking about fractional erbium YAG laser-assisted drug delivery of timolol. Again, nice result for deep infantile hemangioma. So again, I told you, lasers are painful. We're talking about children. So if it works, TIXEL, followed by the application of beta blockers, and if we have good result, especially for the deep hemangioma, if we can use it for short period as compared to topical application, then it's very wise and it will open the gate for many, I would say, other children to be treated. So again, this is a retrospective study. We reviewed all our patients with infantile hemangiomas that were treated with TIXEL, followed by propanolol or timolol. You can see the formulation in front of you. You can see the parameters. Again, in the sake of time, I will skip this slide. You will be able to read it in few weeks. It will be on air. So we reviewed all the epidemiologic data, all the clinical data, and the before and after picture were presented to two non-involved dermatologies. You can see the setting. I will skip it because I want to show you some more studies and then we will get to the Q&A, but you can read all the parameters. But one thing to mention, and it is very important, please have a look. The duration of treatment was 4.36 months in average. And we think that generally speaking, again, it still has to be maximized, I would say, the modality in this treatment. But we're talking about shorter treatment as compared to, I would say, just topical application. This is the before, this is before second treatment, before third treatment, and this is 3 months post last treatment. This is the child. Please have a look. Okay, do you see him crying? Do you see him moving? Again, you will see the treatment. Look at the face of the child. This is the mom. She doesn't have to be outside. No need for ocular protection. You can see there is some change in the face. So it's not pleasant, but it's not really painful. It's not laser. Before and after, before and after, before and after. I have to mention that this study has many limitations. This is a concept, and this is very small population. And again, it introduces a small, very easy to use drug delivery system. It's sterile. You don't need ocular protection. So it is very important. But the main question, and so we know that we enhance the delivery into the epidermis, but there is another barrier, which is the stratum basale. What is the correlation between the epidermal, the timolol in the epidermis compared to the dermis concentration? What is the most beta blocker molecule? So timolol, propanolol, you can read it, all the assumptions in this study that will be published. What is the best regimen? To do it once every 10 days? To do it, again, you will be able to read all speculation in the study. I will skip this one. I'll just show you one case. This is a study. Again, you can read it. This is port wine stain. This is a patient that came to us. He was treated when he was a child by pulse dye laser. Several studies. This is his picture when he was 15. We tried just pulse dye laser. It wasn't very efficient. And then we decided to add rapamycin, which again, this is very controversial if it assists. So one side, you can see we did pulse dye laser followed by the application of rapamycin. The other side is pulse dye laser, TIXEL and rapamycin. You can see, okay, you can see the vascular filter of the visia. And I'm sure you can appreciate that if you look at the pulse dye laser, TIXEL, rapamycin, and this is the clinical picture, we have better aesthetic outcome. Again, this is a very small study, 3 cases study. We do know that the lateral side is improved better compared to the more medially treated side. And I have to say that we do have some other cases. Again, you can see the cases, this just middle area was treated with pulse dye laser, TIXEL, and rapamycin. We have improvement, but the result, and I cannot really explain, they are not reproducible. So we do have patients and we do have children in which it had no effect on the improvement. So we didn't see more improvement with this combination of pulse dye laser, TIXEL, and rapamycin. I will end up with scars, and then we will allow questions. So I'm sure if I ask you what would you do for this patient, all those modalities would have been mentioned. Pulse dye laser, CO2, non-ablative fractional laser. I'm sure you would add maybe cryotherapy, and maybe you will add injection of triamcinolone 5-FU. And let's say this patient doesn't want to be injected. So this was the first publication that came out. This is a publication, we call it the scar pain without the pain. And we showed that we have some improvement with just TIXEL, followed by the application of triamcinolone 5-FU. I would say that talking about adult population, I wouldn't use it. But let's go to the pediatric population. What can you do with this child? This is a 4-year-old girl. She got burned when she was 8 months. So if you want to offer any treatment, we're talking about multiple session, very painful. This is a widespread hypertrophic scar, so it won't be a second. So it's relatively long treatment. You will have to sedate her. So to sedate the child every month. So what we developed and we actually published, again, this is a publication that you can read. This is TIXEL followed by triamcinolone 5-FU and sonophoresis. You can see how we do it. We discharge our patient, though I'm not sure it's really needed, with Tegaderm in order to ensure that the scar is saturated with triamcinolone and 5-FU. This is the before and this is the after. Again, this is closer magnification. And you can read, we described 4 patients. We have very nice result. And I think for the pediatric population, it will open the gate for more studies and for more treatments which are non-painful. And this is the most important. I will finish up by saying that you're familiar with lasers and we are familiar with radiofrequency. TMA, TIXEL, thermomechanical ablation, this is a different technology. And you can see the comparison. If we look at the TIXEL, you have to think into 2 directions, the high setting and the low setting. The high setting are used for rejuvenation and the low setting are used mainly for drug delivery. The advantage of this drug delivery that it's very compact, very easy to use. It's sterile, you have no pain with low energy, you don't need ocular protection, and this is very important. Which drug, which formulation, which patient for the different indications that I mentioned. Again, this is just the beginning. It's an interesting beginning, but there is still way to go. And with that, we are going to finish. I thank you for listening. And I will thank my group in the hospital and my group in my private clinic. I told you all studies are not one man's work. It's always a teamwork, and I have very, very good 2 teams. So thank you very much. I don't know if you're here, but thank you very much if you're listening.